welcome to the last Asia Ventilation Forum podcast. I am here with Professor Mitchell Levy of Brown University. We are very, very thrilled that he is here to talk to us about the Surviving Sepsis Campaign. I think everybody knows that Professor Levy has been instrumental to the formation of the Surviving Sepsis Campaign and is one of the senior authors of the 2021 iteration of the guidelines. So good evening, Professor.
Good evening, Jep. It's a pleasure to be here.
So we're not going to go, we're just going to go straight into it, actually, because there is a lot of stuff that we would like to talk about when it comes to sepsis.
Great.
I think what we will do is we will talk about the stuff that have been sticky for a lot of our colleagues, including myself, when it comes to taking care of these patients. Unfortunately, it is one of the most dangerous and most common enemies that we have in the ICU. So we're just going to be going through some of the points that were raised in the guidelines and then pick your brain about them. All right?
Please. Sounds great.
All right. So one of the things that we noticed, actually, and especially during the pandemic, was the rise of a lot of fungal infections. And we do know that if we are delayed in antibiotics for bacterial infections, the mortality for sepsis patients increases. But I was wondering what your thoughts were regarding the initiation of antifungal therapy, because I find that a lot of people do not start with the very strong antifungals. They actually creep up rather than start like an analog of broad spectrum and then go down.
Yeah, so this is a very challenging question. And you said it very well, which is people are hesitant to start antifungals. And the problem is, by the time there's a fungemia, that is, that there's a fungal element, whatever it might be, growing in the bloodstream, even treated, the mortality is 50%. So in many ways, the appropriate treatment for a fungal superinfection is suspicion and early treatment.
Thank you.
And if you noticed the most recent guidelines, we basically said yes and no. We said for patients who are at high risk for fungal infection, then we recommend giving it. And it was a weak recommendation, a suggestion, and a low quality of evidence. And at the same time said, for people who are at low risk, we recommend against it. So it's not surprising to me that this would be confusing for clinicians. And to make matters even worse, we didn't really define what high versus low risk is.
There was this one rather long table about which patients may be at risk for fungal infections. I remember that in the guideline, which I thought was helpful. But as you said, maybe how high is high and how low is kind of still clinician.
That's right. That's more like it.
Judgment.
And really, there's no appropriate answer. Certainly, waiting in a neutropenic host who's not defervescing at the end of 5 days, 7 days at the most, and being hesitant to treat that patient with an antifungal agent, I think we're suggesting is a mistake.
Okay. Well, thank you for those answers. I know it's still tough when it comes to when you're at bedside.
Well, I think that's exactly right. And I think the decision of who's at high risk for a fungal infection is still not clearly defined, but it's not just neutropenia. It's people who are otherwise immunocompromised, who are not responding to broad spectrum antibiotics. And I hate to say clinical intuition, because we don't know what that means, especially for evidence-based guidelines. On the other hand, the bottom line is if you have somebody who does not appear to be responding to broad spectrum antibiotics, in whom you're worried that if you make the wrong guess, their likelihood of mortality shoots up, then I think starting an antifungal agent is the right thing to do.
Thank you. Well, that's actually for everybody that is listening, because we feel that sometimes we're kind of late, and when these do happen, well, we would jump over now to one of the stickier points, which a lot of people get tripped up about, which is fluid management, which I think should have already been kind of basic when it came to sepsis. But a lot of people are still in debate regarding the things that we're going to be talking about right now. So the first thing is about the, obviously, it's about the volume and the volume status when we're doing the initial resuscitation. So the guidelines did state that we would be using 30 mLs per kilo of crystalloids, and initially within the first 3 hours of the recognition of sepsis.
That's right.
I do notice that in a lot of social media platforms, actually, a lot of people are questioning that specific portion of the guideline. Care to comment about that?
Well, I've spent countless conferences doing pro-con about fluids and sepsis, and I want to point a couple of things out. First, there's no right answer. However, the 3 major trials in early goal-directed therapy, PROMISE, PROCESS, and ARISE, from the US, the UK, and Australia and New Zealand Intensive Care Society, all of them, their standard of care before randomization was 30 cc's per kilogram. So I actually feel very strongly that they established that 30 cc's per kilogram was the standard of care for fluid resuscitation in sepsis and septic shock. And so before they randomized anyone, they said, all 3 trials said, you have to give 30 cc's per kilogram before you do anything else, before you randomize them. Second point that I think is really important is a lot of the argument, and this is, we're going to talk a little more about this, but there's a US-based trial called the CLOVERS trial. Mm-hmm. So the CLOVERS trial, which is a very important trial that was formerly known as the ARDSNet and now is known as the PEDAL network, they're starting with 1,000 cc's, a liter. So I always have to point this out to people, because this argument is about the difference. Let's say the average person is a 70 kilogram person. So we're talking about the difference between 1 versus 2 liters of fluid. And I feel like, just as you said, yep, there's so much social media saying that we're killing people with 2 liters, 2,100 cc's, when actually even the most conservative fluid approaches is starting with a liter. So all of this argument, and as we would say in the US, hand wringing, is about a liter of fluid. I mean, let's keep that in mind. We're really having all these debates and all these arguments about 1 liter of crystalloid. And as we know, only about 25% of the liter of crystalloid we give stays in the intravascular space. So we're not arguing about very much fluid here. And I think those 2 points are very, very important to keep in mind.
I think that you should come to the Philippines, where we do a lot of hand wringing over 250 mLs.
Yeah, I mean, it's great that you're saying that, because when I give a fluids talk every month to the internal medicine house staff who are on service in the intensive care unit. And I always ask them, okay, you have someone who's not peeing in the middle of the night. How much fluid do you give them? And these days, it's been years, everybody goes 500 cc's. And I go, that's not true. Come on. And people give 250. So 25% of 250 is about 60 cc's. That's and right. So then we give people 2 medicine cups of fluid and then say, okay, are they peeing? I mean, that's silly. It's ridiculous.
Yeah, well, I use tablespoons when I talk to my residents about that. So 4 tablespoons.
Exactly right.
Thank you for that. So beyond the volume, there was a really good discussion also about crystalloids, the need, the evidence behind using balanced crystalloids. But I think that one of the things that I found interesting, or thing I wanted to talk to you about, was about albumin and when to actually use albumin, and what would you say would be the best practice around the use of albumin in sepsis?
Great question. We've mixed a whole bunch of things of balanced versus crystalloid, normal saline, but I will, since you allowed me to, I will sidestep that for now.
All right.
I do think, and we know this, and my good friend Jean-Louis Vincent is fond of saying this, that in patients who have low albumin levels, who receive large amounts of crystalloid in resuscitation. Now, large amounts is, again, what does large amounts mean? But let's say 2 to 4 liters of crystalloid. If someone's in shock, or even if their kidney function is impaired and they present with a community-acquired pneumonia to the emergency department, in my institution, they're likely to get between 2 and 4 liters of crystalloid. Now, if that person started with an albumin level that's below normal, we know by definition that they will have diluted their oncologic pressure, right? And so that's why we suggest, and again, this is a suggestion, that for patients who receive large volume crystalloid infusion, that especially if they're hypoalbuminemic to begin with, that we supplement their fluid resuscitation at a certain point with albumin resuscitation. And we do the same thing. I feel, especially if someone in our metrics, it's less than 3.0. So I don't want to, I know how dangerous it is, but to quote numbers, but in someone who is hypoalbuminemic, I would suggest that after 2 to 4 liters of crystalloid, whatever the crystalloid of your choice is, that if they start hypoalbuminemic, that we go ahead and give them some albumin in addition.
And you would be using the 4 or 5% albumin rather than, I see some clinicians using hyperonchotic 25.
Yeah, we don't use that, but I think you could make an argument either way. It's what you're really targeting here is albumin supplementation. And so I honestly think if you want to just use a little bit of salt, hyperonchotic, salt poor albumin, that's not unreasonable, as long as you then immediately go back to your crystalloid infusion. So if you think whatever mechanism for hemodynamic monitoring you use, if you believe that someone is still under resuscitated, you still have to go back to crystalloids. And on the other hand, if you want to use a liter of 5% albumin, that's not unreasonable as well.
Thank you. So, well, we did sidestep, the balanced crystalloid and the saline question. But I think it would be a great opportunity to talk about that right now.
I didn't think I'd get away with that.
So right now, so what would your practice be like when you are resuscitating someone in the beginning? This is before the albumin, obviously.
Yeah, so it's interesting. For years, as a medical intensive care unit person, I would always say there's never a reason to use lactated ringers and or balanced salt solutions, like we would say plasmolite, right? And but the data suggest that using normal saline, and we know this for years, that the most common, for instance, metabolic derangement in a trauma-intensive care unit, at least in the United States, was hyperchloremic acidosis. And there are some data, retrospective, granted, that suggest that hypochloremic acidosis is associated with increased mortality, confounded, no question, by severity, et cetera, et cetera. But there are a number of fairly well-done randomized controlled trials that have had mixed results, the most recent of which being the SMART trial, which did demonstrate a survival benefit for a balanced crystalloid. So we, in our ICU, routinely use lactated ringers as a balanced salt solution.
We have been doing the same since that data started coming out. So I like to sometimes boast that we were ahead of the curve for a little bit when it came
I
to
agree. And
I
think the important thing to mention here is, unlike, for years, I lived through the albumin, as you said, 5% albumin versus crystalloid argument. And in those days, and now, albumin is certainly much more expensive than crystalloid. And so there is a huge difference, but the difference in terms of cost and impact of normal saline versus lactated ringers is like nothing. And so there's no harm in using LR versus normal saline. That's why we've completely switched over to lactated ringers.
I'm glad to hear you say that, because it selfishly validates our own practice. Regarding one more fluid, which I think we needed to talk about, was bicarbonate, actually. Well, a lot of people still use bicarbonate almost like a salvage therapy in sepsis. And I was wondering about your thoughts on that, and also in light of the guidelines that have been published.
Yeah, I'm trying to be objective about this, but one of the first manuscripts that I think I've ever written was an article for, I think, critical care clinics. I want to say 1990, but might have been earlier. And it was a review of the use of bicarbonate in resuscitation. And in those days, it was CPR, but the data are really clear that there is no benefit from using bicarbonate-based solutions in resuscitation. And what's ironic is, if you look in the literature, people talk about, well, unless someone's less than 7.1, or unless that someone is less than 7.0, and all of those targets were completely arbitrary. There's no level at which, and Hal Weil, who's one of the godfathers of critical care and one of the early presidents of the Society of Critical Care Medicine, wrote a lot about this. And he did some elegant dog models where he showed that giving someone with a sluggish circulation, and a dog in this case, an amp of hypertonic sodium bicarbonate increases, because of the combination of hydrogen ions and bicarbonate into CO2 and H2O. And so therefore slows down the diffusion of carbon dioxide from the cardiac veins into the circulation. And what Howe was able to demonstrate in animal models was that the best predictor for resuscitation, return of spontaneous circulation in a dog model, was actually the CO2 gradient and the intracardiac vessel CO2. So he very convincingly, in many ways, Hal was responsible for the change in recommendation during CPR.
Right. When they dropped the use of bicarbonate, which unfortunately in my country they still use from time to time.
I've had a number of residents who will hide their use of bicarbonate from me when I come in to a code, and I've had to say to a few people, don't stab yourself with the bicarbonate amp because you're worried about my reaction. And it's become a running joke, but the truth is, our recommendation really in 2021 was unchanged over the last, I think, since the beginning in 2008, which is recommending against the use of bicarbonate. Now, having said that, and if you look in the rationale of the current guidelines, there was a 400-person randomized controlled trial that looked at the use of sodium bicarbonate. And the overall mortality, the primary outcome was, I believe, 28-day mortality, and I can't remember what the second. It was an aggregate outcome, but there was a subgroup of about 130 patients who had renal failure and a few other things, and it showed a benefit in a small subgroup. But the important thing to mention there is that's in the face of increased hyperchloremia. Well, all of the things that you know that the administration of bicarb leads to, hyperosmolality, et cetera, et cetera. And so I personally, and again, that's why I said I'm trying not to be biased, I'm personally convinced that there is just simply no reason to give sodium bicarbonate to someone, not just CPR, but someone in septic shock with a low pH.
Right. Thank you for that. Yes, so you were mentioning about that Bicarb trial, I think. So now what some of my colleagues have been doing was to basically start the bicarbonate anyway, because of the once there is evidence of kidney injury, citing the potential benefit for delaying renal replacement therapy rather than a survival benefit.
Yeah, I think that's right. What I would say is the most important thing is you're going to put 2 or 3 amps of bicarb into a liter of free water, D5W. And so now you've essentially recreated normal saline. If you're using 3 amps, then you do run the risk of the same hyperosmolality. On the other hand, this is one of those gray zones. And we've learned to live with these gray zones in critical care. So do I jump up and down and scream when someone tells me that they're giving a couple of amps to 3 amps of bicarb in a liter of D5W as a resuscitation fluid? It's not worth the fight. And I am someone who does not believe in subgroup data. And so, on the other hand, I don't think it's inappropriate to do it, Jeb.
Thank you. I mean, I'm really happy to hear someone with such experience and such gravitas talk about this. I can't wait to share this podcast with so many people. So let's move on to the other portion, which is renal replacement therapy and the timing of it, because at the moment I'm seeing a little bit of a disclosure. I still practice by telemedicine in the United States, so I'm able to see some of the different systems that take care, obviously, of patients with sepsis, and I'm practicing here in the Philippines, where in one of the more resourced hospitals, actually. So we do have the capability to do continuous renal replacement therapy. So when we start talking about the need to do renal replacement therapy, the timing is always an issue, and I'm surprised at the variation that we can see between the two countries where I practice in, and actually between clinicians, between nephrologists and some of the intensivists too. So could you comment, please, on renal replacement therapy in sepsis and clear it up a
Yeah,
little.
I'm interested in this because I have to admit I'm puzzled by this. I want to say this appropriately, but for years as intensivists, we all tried to prove, and again, my good friend Jean-Louis Vincent had a really good early phase 2 trial on early renal replacement therapy as a method for fluid resuscitation, for fluid removal, and for resuscitating people in sepsis. And all the early trials, all the trials in early CRRT in septic patients have been negative. And I have to confess, this one I don't understand that well. It's not just CRRT, continuous renal replacement therapy, versus intermittent hemodialysis. It's also early versus late. And yet every single trial, and that's what we say in these current guidelines, they've all been negative. So this is one of these, for every PICO question, right? So the PICO questions are the questions that we ask of each group, and each group develops their own PICO questions, whether it's for renal or ventilation or et cetera. They develop their own PICO questions. And then we look to see if there are any new data, especially randomized controlled trials or large prospective cohorts since the last iteration of the guidelines, in this case 4 years ago. There were none. And yet everybody, I want to say up front, I have colleagues who are really brilliant. They're publish frequently, and they believe that early CRRT is better for you. And I have to say that flies in the face of all the published evidence of randomized controlled trials. There are just simply 0 RCTs which even suggest that early RRT or RRT versus IHD is better than each other. And so this is one that I definitely feel puzzled by, because in the absence of any evidence, I think we make ourselves feel better. And maybe we're trying to remove some of the aggressive resuscitation they get in another hospital. I'm just trying to project why someone might feel comfortable, but there just are no data to support it. I think honestly, Jeff, of all of the things that we've talked about, this is the one that I feel the most strongly about. There are so many gray zones in what we do, but this one, believing that earlier CRRT or CRRT versus IHD is better, just is unfounded. There are no data to support that.
Well, thank you for saying that very clearly for our audience. There was one topic that I actually skipped over, which I had promised Jason Fua that we would talk about, and I really was interested in it regarding the vasopressors. So, right. So, sorry, I skipped that portion, but we wanted to talk about the use of vasopressin specifically. So we're clear on the use of norepinephrine as our first line, and the context of this is kind of weird. When I was training in the US and in the systems where I practice right now, I find that they would have an upper limit sometimes of norepinephrine of around 0.4 mics per kilo per minute.
0.04.
0.4. It will be their upper limit, 0.4 mics per kilo per minute. And here in the Philippines, we frequently use that as our starting dose, actually. So
I'm sorry, you were saying norepinephrine, not vasopressin. I apologize.
Yes, sorry. I was talking about norepinephrine. So that's the context. And I find in the US, they're using norepinephrine at those kinds of doses. They'd have an upper limit. Here in the Philippines, we start off at very, very high doses already, and frequently go up to around 2 or 3 mics per kilo per minute. And then we would be using the vasopressin at around 0.4 mics per kilo per minute, because in my head that was the max of norepinephrine in my training. But and therefore I needed to use something other than a catecholamine. But we find in the guideline that there's a little mention there about the practice of 0.25 to 0.5 mics per kilo per minute of norepinephrine, and then we add on the vasopressin. Could you comment more about that, please?
Yeah, this is another one of those not so delightful gray zones. Okay, so first, norepinephrine. I want to address what you just said about norepinephrine. I don't believe in a maximum limit of norepinephrine. I think it's a dose response, and most of my colleagues, academic colleagues, and I know in my own unit we practice this way. There's no such thing as a maximum of 0.25 or 0.5 or 40 mics per minute. This is like, as long as you have a young patient who continues to respond to norepinephrine, you're going to increase the dose. And Dennis Edwards, years and years ago, published something where I think he was using some ridiculous, like 1 to 4 milligrams per kilogram per minute. And I feel like that's not outrageous. If a patient responds to your increased dose of norepinephrine, by all means, you should use it. So I will often, as will all of the attendings in my ICU. Now the nurses never do this anymore because we understand it, but they understand it. But we're not. There's no arbitrary maximum of norepinephrine. The maximum is when your patient stops responding to increased doses of norepinephrine, then you're done. So that's one. That's very important. The second is, what dose of norepinephrine do you then start vasopressin? Now, first of all, that already crosses international, in what we say is it crosses the Atlantic, because the Europeans really like norepinephrine and epinephrine, and the Americans like norepinephrine and vasopressin. And I honestly, we've argued about this for over 10 years in the Surviving Sepsis Campaign group, and there's no answer to this, because nobody is going to do a study of those combinations of agents, right? So what you're left with is a couple of trials, the VANISH trial and the VAST trial, which literally looked at what happens when you add when you add vasopressin to norepinephrine. And they had inconclusive results. And especially the VANISH trial, as we know, had no statistically significant signal. The VAST trial had no statistically significant signal because they anticipated that in the higher doses, vasopressin would be sparing, and therefore that would be beneficial. And it turns out in the low doses, less than 15 mics per minute, there was a survival benefit. Mm-hmm. So that's the basis for our recommendation of 0.25 to 0.5. It's and if you look in the rationale, it's I think it says something like it's reasonable to add vasopressin at 0.25 to 0.5. And honestly, we push. I will tell you my honest practice in our ICU is we push norepinephrine until we don't get a dose response, and then we add vasopressin. That's just the way we practice. We recommended, and remember that all of the recommendations in the campaign is an 80-20 consensus vote. And so we may get to this eventually with antibiotics, but if you're in the 20% minority, that's the recommendation. And we felt very strongly early on in 2008 that we don't need minority reports because already the guidelines, because of the gray zones, are confusing, let alone if people felt like they were allowed to write a minority report. And so this is one of those cases where I feel I have colleagues who will add vasopressin more quickly, and that's reasonable. We push norepinephrine to its max, and then we add vasopressin. I honestly don't think you can provide data that will conclusively say that's a mistake.
Thank you.
I almost feel like I want to say sorry, Jeff, but it's just the truth of it.
Yeah, that's how it is.
Yeah.
Well, thank you for that. These are the kinds of things that we always struggle with at bedside, and I know that a lot of people have been having these kinds of questions. So I'm really, really happy that you're here to talk to us about that. Now, we are almost at the end of our podcast. I was wondering, what other questions would you like to see addressed actually in the next iteration of the guidelines, especially since our podcast is actually mostly an Asian-based and project. And so a lot of people are going to be listening from the countries in Asia. And I think we have not been represented very well yet in the sepsis studies nor the conversations, and therefore maybe what do you think we can help with when it comes to the next iteration?
Well, that's a really great and wonderful question, Jeff. And I will tell you that there are a couple of things. The most important is how much fluids. It's amazing to me, having practiced this for more than a couple of years, that we still don't know how much is enough. And we already talked about the amount of fluids that's appropriate. I think the big next question that I'm hoping the Clover's trial is going to address, but certainly if an Asian consortium leads, it would be really valuable to know how much fluids should we be giving initially to someone who is septic, or for that matter, in septic shock. I think that still remains the biggest unanswered question. I think a less unanswered question, and this is maybe a little off topic, but what hemodynamic monitoring is best. Every time I am always fond of doing the pro cons, and I take the con because the English, the UK folks love transesophageal echoes. Some of the Europeans like either pulse pressure variation or they like PICO. And I just feel like after 30 to 50 years of critical care, we have not yet answered the best form of hemodynamic monitoring. That's astonishing to me, right? And I honestly don't think we're going to be able to answer that because each culture is different, each nation is different. And so I feel like that's a question that I don't want to answer in the next guidelines because every culture has their own opinion. And to me, this is like, whatever you're comfortable with, do that. And yes, the Americans take a lot of flack because we still use PA catheters. And as I already described some of the other cultures, I don't think one thing that's clear to me is no one has proven that one form of dynamic hemodynamic monitoring is better than the other. And I think we have to kind of put that to rest a little bit. So those are my two comments.
I like that you're able to share your the areas of doubt or areas of uncertainty, not doubt. Okay. Well, before we end, would you have a message for our listeners and our viewers, actually, Thank you again for your for being here. But did you have final words to share?
Yeah, I've said this in a couple of talks internationally over the last. Thank you for asking, Jeb. I will say, especially during this pandemic, where we're all feeling so uncertain and are often challenged by families to provide things, we have to rely on evidence-based medicine. As good as whatever we understand, I will say that we cannot let our helplessness interfere with our understanding and appreciation of evidence-based medicine. Because unless something is proven, we just can't offer it because families are asking for it. That we know the danger of doing that. And I would caution all of us, myself included, and we have so many families who come in and say, oh, I've read something on the internet. Whether it's, by the way, the pandemic or sepsis in general, they'll say, oh, you should use fill in the blank. And I have to say, unless it's proven by a good trial, I'm not going to give this to your loved one. And I think we have to trust that. We have no choice. So that's it.
Well, thank you very much for saying that too, Professor Levy. So I'm going to end this session. This has been a wonderful discussion with Professor Mitchell Levy about the Surviving Sepsis Campaign and a lot more things about critical care and a little bit about how things are developed in the guideline world. For example, I learned a lot from you today, sir. Thank you very much.
My pleasure.
So this has been the final podcast of the year for the Asia Ventilation Forum. Thank you, everyone, for listening in, and please subscribe to our YouTube channel. Thank you.
Thank you.